You. Great. Okay, why don't we get started just in the interest of time? So, welcome everyone to the third annual installment of the Learning Health System or LHS seminar series. I'm Saumia Mayapin. I'm manager of the LHS here at Women's. It's great to actually see a lot of new names and faces who are joining today. And I do want to give a special welcome to members of our Community Liaison Advisory Committee or CLAC, to whom we've extended an invite this year. So CLAC is actually a group of experienced advisors that serve as an advisory body to the hospital on community identified needs and gaps. And they also work on ensuring that hospital programs meet the needs of patients and diverse communities. So really happy to have them joining us going forward. Because this is the third season of the series, I am really delighted to share that we have an exciting lineup of speakers for this coming year. And in particular, we've chosen to highlight a lot of impactful initiatives that are taking place right here at Women's. So that includes today's seminar, if you're familiar with the schedule for today, where we'll feature two key clinical programs. There's TAPMI, the pain program, as well as cardiac rehab. And the whole idea is to show you that this idea or this journey of moving towards a learning health system, it's not as daunting as it might seem, especially when we have areas within the institution that are already kind of operating in line with a model like this. So how are they taking a data-driven approach, generating knowledge and embedding that back into care plans, and or evaluating what they do to generate the care for tomorrow? We'll find out more today. So please keep an eye out for our upcoming schedule on our website, as you can see highlighted on the slide here. And of course, you can feel free to reach out to me if you have any questions. Now, before I turn it over to our esteemed speakers, I would like to give a land acknowledgement. So we acknowledge that the land we work and meet on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Okay, so I'm pleased to introduce our first speaker, Dr. Rachel Bosma, whose talk is entitled TAPMI, a Learning Health System in Action, Data-Driven Approaches to Improve Access, Equity, and Outcomes in Pain Care. Now, Dr. Rachel Bosma is the research lead at the Toronto Academic Pain Medicine Institute. That's what TAPMI stands for. And she is also an associate scientist here at Women's and director of the University of Toronto's Center for the Study of Pain. Her research advances new models of chronic pain care and health system innovation, supported by over 18 million in funding and over 50 publications. She also co-leads national initiatives such as the SPORE Chronic Pain Network and the Power Over Pain digital portal. And if I can add, for the third straight year, Rachel and myself, along with Chandra Ferrer, will be co-chairing the annual Day of Excellence in Academics. That's taking place next April 16th. So please stay tuned for more details and take it away, Rachel. I'll stop sharing my slides.
Thank you so much, Samia. Let me go ahead and share my slides. An excellent plug for the Day of Excellence. Please stay tuned and everybody join in. As you'll see today from my presentation, how you can be part of this, how we're all part of this journey to become a learning health system. And thank you so much for the invitation to showcase how TAPMI is doing this right now. Okay, we often talk about the need for the right care at the right time in the right place. And in the context of chronic pain, the right care is personalized because pain is never a one-size-fits-all solution. And the right time, we're talking about a lifetime because we're talking about a chronic disease and there's no quick fixes. And the right place really means that thinking intentionally about access to effective care wherever, whenever the patient actually needs it. And that's really the challenge that we are trying to solve together. But getting access to pain care can be the challenge in and of itself because you know what? Many people do not know where to go. The health system is really confusing. Not all healthcare providers know about chronic pain or how to approach pain care. Referrals can bounce around a health system from one provider to another. Wait times, always an issue, stretch for months, sometimes even years. And at the very moment where people are the most vulnerable and need the most help, the path forward can feel unclear or fragmented and quite frankly, overwhelming for a lot of people. And you know what? These barriers are not always felt equally. Services are unequally distributed, and the obstacles are greater for some than they are for others. But who are we really talking about? We're talking about women. Women have a higher prevalence of pain. They have higher rates of pain-related disability, meaning that it impacts their day-to-day lives extensively. They have more likely reoccurrent or severe or longer-lasting pain. And at the same time, women, and historically, and we're working to change this, have been excluded from research. So we don't really know a lot about pain and pain conditions in women. They haven't always been taken seriously about their pain, and they have less access to pain care. And I care deeply about how we can change this. And I'm really privileged to work within TAPMI, the Toronto Academic Pain Medicine Institute, right here at Women's College Hospital, where we all care deeply about changing this and about seeing things differently. A little bit about TAPMI. TAPMI is a partnership. We partner with five institutions across Toronto, and together we created a streamlined pathway for care. We have a single site entry or a common referral and triage hub that's situated here at Women's. And that means that if you have chronic pain and you're looking for specialized care, you're looking for access to our services, you no longer have to guess which clinic, which hospital in my slide here is right for you, has the care that you need. Your paperwork gets sent to us at Women's College Hospital, and we look at what your needs are, what you're facing with, what you want, what you have access to, what your preferences are, and we send you and we distribute care across our partnership accordingly, matching your needs to the services that are best suited to address these needs. Now, this might sound small, right? This is just paperwork flowing from in one place, flowing into one place. But it's actually transformative for a number of reasons. It allows us to deliver better care faster and more fairly. And this is where a learning health system really comes into play. It allows us to look very closely at who is coming in our doors, what their needs are, what their preferences are, what they have access to. But it also lets us look at who is being left behind, who is not getting in our doors, why not? What can we do as a health clinic, as a health system to address these gaps in services? So let me give you a little example of what this looks like. So I'm going to ask everybody online to think back to 2017. It's a while ago now, 2017. So what was happening? Well, the Me Too movement was going global. Wonder Woman was killing it at the box office. What else? Taylor Swift was probably doing something amazing. But here at TAPMI, something else was happening. Women were being referred to us for chronic pelvic pain, a lot of women. And at that time, we didn't have anything for them. We didn't have any designated services to address their needs. We didn't have providers in place to provide specialized care for this population. And in just 1 year, we had over 300 referrals accumulate. And this told us something important. There was a major unmet need for care in this population. And so we acted. So we got together and we said, what can we do about this? We reallocated resources. We strategically hired the right staff, ready and equipped with the expertise to provide services for this population. But we also partnered. So we looked around and said, who else is doing this? What can we learn from them? And we partnered with our patients and with our experienced advisors to co-design an interprofessional pelvic group program. So we listened and we learned and we worked together to say, if we're going to develop something, let's be smart about this. What are the needs and how can we access them? address them. And we worked across our partnership, and we worked in partnership across the clinics in the hospital. So partnering with gynecology to build one of the only chronic pelvic pain programs in the province.
Rachel, I just wanted to just address the audience. If you could kindly mute your mics, that would be great. Thanks.
Thanks, Samya. So we didn't stop there, right? A learning health system, you're never done. So what's the next iteration? That's what we learned. That's what we did. That's how we acted. But we continue to collect data. We looked at our information, what was coming in. And another pattern emerged. So we noticed that our patients were waiting a long time to access our services. So we built them, but we have limited capacity, and there were still long wait times and a backup of wait times. And so we brought our team together in a true learning system fashion as, well, what can we do during this waiting time? How can we prevent waiting from becoming suffering? Because we know that when people wait on wait lists, like, the problem does not go away. Health outcomes become poorer, health deteriorates, outcomes or expectations for outcomes soar. And we thought a lot about, well, what can we do in this waiting period to support patients? We recognizing the limitations. If we had additional clinical resources, the wait times wouldn't have been as long, right? I mean, more staff, more money, bigger programs, but that wasn't what was available to us. So we sat down and said, what can we do now? And in response, we created an evidence-informed self-management program to guide patients while they wait for care. And this program was designed collaboratively with people with lived experience, with our interprofessional staff, with lots of vetting, and we really work together so that people can understand their condition earlier. So that was one of the first things that we learned. So we went to our patients who had been through our program and asked them, like, you've been through our program, what would have been nice to know while you were waiting, right? And we learned, well, I wanted to understand my disease. If I had come into your doors understanding my disease better, we would have been in a different situation and the conversation would have gone differently. You provided a lot of access to resources that are ongoing in the community and pointed me to different services. If I had known that, I could have acted on that sooner. And I had put my life on hold till I got to your doors, and I didn't need to do that. And so through this program, and it's an online self-directed program that we created, this ensures that education and this support are not delayed just because appointments and getting in our doors can be delayed. So we then received CIHR funding and AMO funding to evaluate this program, and this continued to snowball. So we didn't want this to, stay within our institute for only our patients. And you know how things go. You create a program and it's great and you use it, or it sits on your shelf after you've done evaluating it. But we really wanted this to be useful and used. And so we received Health Canada funding to build what we call the Power Over Pain portal. And this is a huge national online platform that curates a number. So our Pelvic Empowered Management is one program that sits on there, as are a number of others. So we're trying to take out the work of having to find these services, having to find these amazing resources that exist, and we've put them in one place and we've made them freely available and accessible. This platform is available. We have a kids portal and an adults portal. It's in English and in French, and we're continually building out resources in different languages and with different needs in mind. So something to take a look at. You can follow along with the QR code journey that I'm providing for you in these slides here. And through this, just to comment on that, by doing this, it also allowed us, so our patients aren't waiting to receive self-management support, but we've also built out community relationships and partnerships through this. And now we've actually been able to sunset some of our own programming locally at Women's College Hospital because these services are still available to our patients, but they're available elsewhere. And that's allowed us to really focus on the tertiary and the quaternary care that only we can provide. And so this is just saying, it continues. We didn't stop there either. We realized that even when patients were getting into our doors, and rest assured it wasn't taking 11 years to get into our doors, but many of them had been waiting years and years and years for a diagnosis. And this was specific to our population of endometriosis, people with endometriosis. Some of them wait up to 11 years to receive a diagnosis of endometriosis. So as a team, we started asking, Why? Why does it take so long? And what can we do to change this? How can we help get patients identified earlier and supported much earlier in their journey? And so we turned these questions into a grant application, and we received CIHR funding, and that's for our endometriosis screener program, or project that we're taking right now, where we're doing two things. We're validating the screener measure for a screening measure for younger adult women and gender diverse people. And we're facilitating the rapid adoption of this screening tool. We're really trying to say, this isn't an academic exercise. The goal here wasn't to write a grant and write a paper. The goal here was to get people screened faster and to change the trajectory of their care. And so alongside us doing the work to create the screening tool, and that's a huge collaborative effort with expertise, including lived experience expertise. But we want to ensure that the tool is published in such a way that it's useful, it's used, people know about it, and we can start moving forward really upstream in this care journey. I want to switch gears for just a minute here and give you a different example. This was an example that was really coming anecdotally from our clinics. So I don't know if this was an experience that resonates with some of you, but over time, especially past the pandemic, we were really seeing increased complexity in the needs of our patients, specific to struggles with mental health concerns that exceeded, quite frankly, our capacity to deliver support at that time. And what was happening is if patients had complex mental health struggles, they were declined paying care from our services because we did not have this capacity. And so we asked ourselves, is this just a perception or is this a broader trend? We went to the data, we did a thorough analysis where we looked at all of our referrals from 2018 and 2022. And the data really confirmed what we had been sensing. The number of patients that had these complexities of care was increasing, and these most vulnerable patients were falling through the healthcare cracks. And so in response, again, what can we do? Well, this became a core part of our TAPMI partnership strategy, in which we all were seeing this. It was true across our partnership. And so we're making tangible conservative efforts to build capacity to deliver mental health care. And that's in many different ways. So we've integrated psychiatrists, we've partnered with other clinics across the hospital, we've hired psychologists, we've hired to provide one-on-one assessments and therapy. We've brought on social workers to support care navigation. So shout out to Brittany Rosenblum, our clinical psychologist, and Sylvia Gomes, our social worker on our team. And now we're in a much better position to support patients whose pain is really deeply interconnected with mental health concerns. And in this true learning health system model, we continue to monitor, refine our services so that when gaps emerge, we're ready to adapt again. And this is an example of how we're doing that, because after strengthening our psychological support in our pain program, we finally had the expertise and the bandwidth to really start looking carefully and taking a deeper look at the mental health needs of our patients. And trauma kept coming up. And so we had never, up to this point, systematically looked at trauma and the co-occurrence of trauma and pain in our population. So we started asking questions, and we collected data from over 2,000 patients, and the results were striking to us. Over 70% of our patients reported experiencing trauma, and over half of them confirmed that it emotionally bothered them. And so this insight, this changes everything. This changes how we think about our patients, how we approach our patients, but also, motivates what do we do next? How do we provide trauma care, not just trauma-informed care, but also trauma services for our patients with comorbid pain and trauma conditions. And so we started by developing a workshop addressing the issue, educating our patients on the issue, what trauma was, how it could influence and be part of their pain journey. But we're also building out a clinical and research program in parallel. So developing interventions for this population and researching these interventions. And again, we've done this through strong partnerships across the hospital. So with colleagues like Orit Samir, Dana Ross, I'm just going to throw names, Sue McRae, Nancy McCullum, Nilesh Sanji, Kareem Wadha, and many others, we're really building this strong collaboration on new innovative approaches and treatment approaches to address pain and trauma in both of our populations. And I think this is what a learning health system looks like. It's listening to patients, it's asking questions, like addressing the pain points in practice, and using this information to design and test new solutions that better meet our populations. And so from our experience, there are a few key things that have really set us up for success in embodying a learning health system. And I would say one of them is the interdisciplinary nature of our team. So we have expertise from all over the place, and we're bringing them together, not just to practice in isolation or even practice together, but to think together and observe together and to identify problems and work towards solutions. And I'd like to think, as a scientist on the team, that having research really embedded within the clinical portfolio opens up an avenue to have research really connected to care and to have data at the center of decision making, because we think about things differently and we approach things differently and we bring different skill sets to the table. And we're not just trying to have, research happen over here and care happen over here. We're working hard within TAPMI to build those bridges. And this means being intentional and always looking for the opportunity to sit together and say, over here, we're finding this in the information, and to have the clinicians ask questions of the data and to think about what it means and how then we act accordingly based on these insights. Another huge component of this work is having the data collection infrastructure. So we need data to inform care in a learning health system. And so we do this through an orientation session in which we capture information on all of our patients. We were finding that, patient referrals come in, but we had nothing in self-report. So, who are our patients? What are their needs? What are their preferences? What do they have access to, so that we can design care models or models of care that really truly support them. This hasn't been easy. This has been a huge effort to get to the point where we can consistently collect information on all of our patients. It takes a lot of resources on the ground to be doing that work. And then again, it takes a lot of resources to say, okay, now we've got the data. It's not just sitting there, in a file or on the shelf, but how are we routinely examining it and using it to inform what we're doing on the ground? And so I think it's really important that we continue to think about investing in technology and in digital tools. They're essential. We need them, but I think it's also making sure that we're smart about the follow through. So not just buying the tool, but making sure that people are actually using it to meaningfully inform clinical insights and change. So making sure that there's follow through and support to take the tool and make sure that it's used and set up to be used in the way that it can reach its full potential and can augment care. I just, in my last few minutes, wanted to highlight I mentioned throughout my presentation that TAPMI, because we're a partnership, we have our strategy, our partnerships strategy. This ties very closely to our institutional strategy across our partnerships. But I think we've really looked at this in terms of how we can function as a learning health system. And I'm just going to pull out a couple ways within our strategy, how we've set ourselves up and kept ourselves accountable to do that. So really, prioritizing the collection of data and evidence and feeding that into continuous learning. Even in our care models and our delivery models, to take what we have and then to continually adapt and look at different iterations focused on important things like equity. Like, we've got education and knowledge mobilization as one of our core priorities. This is really building out and fleshing out a culture of learning across our partnership, which we foster and we invest in. So we're really trying to make this be everyone's job to do. It's not a research job or a clinical job. Everybody's job is to support evidence-based practice. So where is the evidence coming from and how is it informing the way we deliver care? And then metrics of accountability and measurement, really closing that loop and holding ourselves accountable. So looking ahead, We're, always looking for ways in which we can strengthen TAPMI as a learning health system. Integrated data platforms. This is always tricky when, data is carefully guarded behind the walls of an institution, but our patients are going to different sites. And so understanding their care journeys, what they're receiving, and the outcomes of that is something that we're continually working towards. I would say real-time dashboards. Again, we can collect the data. It's a lot of work. We can collect it, but then how can we use it in real time? And then I think we're all looking towards AI and analytics to see how these tools can be integrated to really enhance and safely augment the way that we deliver care. So I just want to close by saying that when we look at pain care, it's tempting to focus on the numbers. So you can look at wait times, referral numbers. 1 in 5 people have chronic pain. It costs our health system $40 billion. But what a learning health system teaches us is that these numbers are not abstract. Every bar, every line in the graph represents a real person living with pain. And the reason that we collect and that we analyze and we spend time with this information is not just to fill in reports, it's not for a publication, but it's to drive change and to make the system better and to use what we've learned to reduce human suffering in the context of chronic pain and to deliver better care for the people that are represented in these numbers. So I'm hoping that this presentation shared a little bit about what we're doing on the ground at TAPMI to take this seriously, to take data seriously, to close the loop, to have it shape practice. And I hope that it's given you a sense of how we're embodying and looking for ways to continually become a learning health system. So with that, I'll just thank you for your time and your attention and hand it back over to Samia.
Thanks so much, Rachel, and hold for applause. That was amazing. I think that the group really appreciates the numerous examples you provided. I'm sure folks may have noticed in her example slides that Rachel included, that cycle of, taking data from practice and using that data to, become knowledge, and how do we bring it back into care? And I thought that that was super helpful as part of the presentation. And I think that emphasis of the goal being not necessarily always having to lead to a publication. I mean, of course, that's part of it, but let's focus also on how we drive change. So thank you for conveying that message. We'd love to open it up for questions. We do have a few minutes. Great. I see, Andrea, you have your hand up. Please go ahead. Andrea.
Andrea.
Andrea, there we go. Oh, sorry, you've muted yourself.
About that.
Andrea, there we go. Okay.
Right. No, the presentation was really impressive. Rachel, I'm wondering, have you and your team considered this work is really incredible. Submitting to the annual quality, you mentioned awards, I to sort of spread the knowledge and the work, the valuable work that you and your team are doing.
Thank you for that. Yes, that's excellent. I will absolutely bring that back. We have submitted, we have been recipients of that award. And so, various awards across the institution, across different buckets, whether it's the different components, not necessarily the quality award, but I just wanted to say, thank you to Women's for, raising this up and rewarding accordingly against the strategy and giving us the opportunity and multiple opportunities to showcase this work. We really appreciate it.
Thank you. I see Roland has her hand up.
Hi, Rachel. Thanks so much. That was great. I have 2 questions. The first one was that intake you effectively do almost like a little bit of an educational seminar for patients. But what have you ever done that where like this is really like they've been in the system for a long time? So do they get frustrated at having to do this and explain things and like go through things? And have you been able to sort of streamline how that happens for people who are already so entrenched in the system?
Yeah, thank you for asking that because you're absolutely right. So what we have done to support patients while doing this is one, keep it short, and two, make it meaningful and show up for it. So we don't send it ahead of time and we're not like, here, fill this in endlessly, and then you may or may not see it actually come into play with your care. We actually integrate it as part of the orientation, as part of how we learn about you. And we have people kind of stay online. We have, a support person actually stay there with them if they choose to fill it out live. And we went clinical first. So this is clinical data, what happens with it and what we've shared with the patients. And what we've done a lot of work behind the scenes across the partnership is ensuring that our partners are aware that this information is coming in, that they're using it, that they're reporting to their patients that they use it, because I think that's one thing. Everybody's willing to share, whatever they need to share to get them the care that they need, but they don't want to say it on repeat and they don't want it to just go into some research folder. And so making sure that that follow through is there. So when people fill in this information, it actually gets appended to their referral form in a summary format and actually gets sent to. So the first thing that anyone seeing them in a clinical context, because this is more of an orientation education context, that information's already there. So the idea is we've streamlined so they're not collecting it, again and again and again, or they're asking different questions. We've also really tailored it to ask different questions than they've been asked before. So we're really focusing, because we're trying to implement what's called a step care model, is you really have to understand what your patients have access to, what their preferences are, what they think they need, and really meeting what clinically you think they need with where they're at. And so this is a summary of kind of where they're at. So it's trying to streamline and put that information in front of people to start the conversation off on, and the care journey and the care management plan off on the right foot.
Thanks. Can I ask quickly, and I guess I have two more questions. So quickly, which is the platform you're using for the intake that you then do the streamline and it goes back to the referral?
So the data is all captured in REDCap and then gets scanned into the
thing. Okay, great. And then the next question I had was, if you take a look at your patient population, interestingly, it doesn't reflect the diversity of the city of Toronto. And I was wondering if that was an access issue in getting referred into TAPMI overall, or we're only serving like the downtown core, or who are we serving? And is that something that we need to address in terms of access?
So you've tapped into exactly a question that's on my radar to answer, because that's why collecting this data, and just so everyone knows, we're talking about 7,000 referrals a year. So over time, we have a lot of data to be really speaking at more of a, not a population level, but we've got a lot of information, and that, Roland, is exactly what we want to ask. So a couple things on my radar to answer that question. We know who our patients are, and importantly to me, we know who is not coming through our doors. We can look at, who is the demographic of our population in the city of Toronto. But the added piece that I'm looking forward to is this year, for the first year, the community health survey has chronic pain questions. So I'm hoping that when it comes down and we can access that information, and I don't know how it's going to be all broken down, I'm interested in learning at not just who is our population in Toronto against who our pain population is here, but who is our pain population in Toronto, who's identifying with pain in the city, and what are their demographics, and then how does that compare to who we're seeing through our doors. And then we can really start to look at that carefully. So absolutely on the radar. Thank you.
Thanks so much. I think in the interest of time, we'll have to move on to our next presentation, but that was excellent, Rachel. And folks can please feel free to reach out to Dr. Rachel Bosma with any further questions. Thank you. I'm going to go ahead and share my screen very briefly again to introduce our next speaker. So next up, we have Mireille Landry, who's going to be speaking on behalf of the Dynamic Cardiac Rehab Program on Women's Cardiovascular Health Initiative, or WCHI. Okay, so Mireille Landry received her Bachelor's of Physiotherapy from Queen's University and a Master's of Science from the Graduate Department of Rehabilitation Sciences at U of T. Mireille's clinical background includes cardiorespiratory, musculoskeletal, and exercise physical therapy in acute care, private practice, and ambulatory care settings. She's the exercise coordinator for the Women's Cardiovascular Health Initiative here at Women, Maintenance, as well as a lecturer with the Department of Physical Therapy at U of T. Take it away, Mireille.
Okay, I'll just try to share my slides.
Great, we see your
Okay,
slides.
wonderful.
Yeah.
Okay,
And you just need to go into full screen.
I think I am.
There we
full screen.
go. Yes,
Okay,
perfect.
wonderful. All right, thanks again, Sumia, for inviting us to come share what our program's been doing and showcasing how really we feel we've embedded this idea of a learning health systems model in our cardiac rehab program. I'm presenting on behalf of our small but mighty team and want to give a shout out to Faith Delis Reyes for helping me with the slides for today's presentation. So we, as a cardiac rehab, we have identified our learning system really addressing heart disease in women. And our goal since inception has been to improve access, outcomes, and equity in an underserved population, women living with heart disease. We have really had the building blocks to be a learning health system model for since we've been open since 1996. We inherently are patient-centered, focusing on individuals, families, and the community. Really focusing again on underserviced female populations and switching our attention more present day to really looking at those equity deserving groups and how do we reach out to them. We are data and evidence driven. We are fully supported and enabled by the organizational structure within our programs, departments, and have had the support of the organization over the years. And finally, part of what highlights us as an LHS is really that our program had and still has a culture of ongoing rapid learning and continual improvement. So for those of you not familiar with cardiac rehab, just a little background as to who we are. Cardiac rehab has been defined as the enhancement and maintenance of cardiovascular health through individualized programs designed to optimize physical, psychological, social, vocational, and emotional status. And this is with big picture goal to prevent a secondary event through cardiac risk factor identification and modification to hopefully prevent disease progression and recurrence of cardiac events. Cardiac rehab over the years has been proven to be effective and is now recognized as a core component of the continuum of comprehensive cardiovascular care in Canada for both men and women. Despite this, only 15% of eligible women are ever referred to cardiac rehab. This stat has not improved greatly over our 30 years of existence, and women are less likely to attend and complete cardiac rehab, even if they are referred. And so this idea of, women's heart issues being important, these observations were really made in the early 90s by our co-founders, Dr. Cardiologist Len Sternberg and our nurse practitioner, Dr. Jennifer Price, and they set out to make a difference. In the mid-90s, the timing and the setting was right at Women's College to open the first gender-focused cardiac rehab program. They found in their cardiology practice that less women were being referred to rehab, were showing up to rehab, and were completing rehab. And so they opened a program really to focus on providing tailored, comprehensive care that addresses women's unique needs and barriers to participation. So when we've looked over the years at our patient population, certainly the target demographic is women or people who identify as women who live with a heart condition, maybe are post-event or procedure, or are at high risk of developing heart disease or having a heart attack. These women present to our program, as with many others, with more depressive symptoms, more anxiety, and decreased quality of life life compared to their male counterparts. They tend to be more likely to live alone, be unemployed, retired, or experience scheduling related barriers such as caregiving roles. In our program in particular, we have a high percentage of women that we would classify as frail, accompanied with lower functional exercise capacity, and also who present with a high number of comorbid chronic conditions. On paper and in the literature, these are all factors that have been shown to predict lower rates of referral, enrollment, attendance, and completion of cardiac rehab. Yet these are the women that we're servicing in our program. What makes our program unique is that from, again, the inception in 1996, it was co-created with our stakeholders in mind. So it involved focus groups at the initial phases, and once it was created with women with lived experience to understand what they really wanted out of cardiac rehab, and everything from the environment, the timing, the group sizes, the type of programming was given consideration. And this knowledge helped to inform the initial design and practice of our program, along with, available evidence, knowing that at the time, in particular, women really weren't included in clinical practice guidelines around cardiac health and cardiac care. So we were evidence informed in terms of best practice. The rest of the presentation is going to touch on some of our influence or participation as an LHS model, but certainly our small program has done a lot of work to influence our patient care internally, but also externally for women, women-focused cardiac rehab, whether it's women-focused classes, women's focused programs, but we're happy to say that we've had a broader influence than just our patient care. Our initial program design was really seamless or involved countless continuous improvement cycles over the years that was due to the data that we generated. And so in our early days, we had data collected through a Microsoft Access portal that we would routinely review on an annual basis and really review our patient demographics, the clinical and patient reported outcomes. All of these outcomes were also communicated with patients in terms of a risk factor report and what it meant for their healthcare, quality of life questionnaires, and also including the patient voice in terms of patient feedback and satisfaction, not only sort of pre-post program, but also on an annual basis. This helped to improve our knowledge around what are the multiple comorbidities that these women were attending our program with. How were they presenting in terms of their social determinants of health? What barriers they had to attending our initial assessment and completing the program, and how we could modify or improve our program and practice to meet them where they were. And so this work really informed our self-management and education program that started off as in-person groups and has evolved over time to be sort of virtual education now, so that we have better accessibility and access for patients so they don't have to come on site to Women's College Hospital. We've offered various forms of peer support groups that have been adaptable based on the patient presentations coming in. As an example, we had a year or so where we were receiving a lot of referrals for postpartum women with cardiomyopathy. And even though we didn't have a specific peer group for them at the time, we created one once we saw we had multiple women in different classes that we knew could benefit from connecting with each other. Hearing from the data and the knowledge has helped us sort of update our practice and always be up to date in terms of offering flexible scheduling and programming. We've always offered a form of home programming by phone, and certainly post-COVID, we've entered more into the virtual video era. And we've certainly grown a lot of knowledge and informed our practice around health coaching. All of this has affected the space, the environment, the delivery of how we offer cardiac rehab, from how our space is designed to the individual individual monitoring, the work to rest ratios in the gym, the equipment that we select for success for our patient. And finally, this knowledge has not only improved our practice, but we've been able to influence practice in other areas and form collaborations and partnerships that will affect women outside of the walls of Women's College Hospital. And these collaborations and partnerships aren't just us helping them learn, but we learn and get more data in return that helps sort of complete the cycle again. All of this work has culminated into sort of our ability to contribute on the international clinical practice guidelines on women-focused cardiovascular rehabilitation. And so we're happy that our little program that could, with all of our really practice-based research and learning, has been able over the years to influence recommendations from these international clinical practice guidelines. And the next few slides will just show some of our work that we've done in the areas of the recommendations, so around referral to cardiac rehab, the setting, the delivery, so that women can be successful in attending and completing cardiac rehab. In terms of this contribution to evidence, at the time of our inception, Women's College Hospital had adapted and embraced what was called at the time principles of women's health. And these principles are really based on a social ecological approach to providing women's health. In the 1980s, the key concepts were identified by healthcare practitioners and organized into what turned into the principles of women's health, which are listed here. So empowerment of women, having a broad definition of health, collaborative practice, accessible programs, high quality of care, and innovative and creative approaches in programming. These principles of women's health were validated by staff and patients at Women's College Hospital at the time, and in the 90s really informed how we created our program. And our early evidence or early data in terms of how our program was successful, really it helped us achieve an 85% adherence rate at 6 months through our program, which is much higher than women attending other cardiac rehab programs. We've also been able to shift our focus to, similar to Rachel and the TAPMI program, shifting our focus to who wasn't attending our program, and found that 24% of the referrals that came to us didn't actually start at have an initial assessment with our nurse practitioner. And so we were able to do some work to talk to those women who didn't come to our rehab over a period of 3 years. And we're able to identify many of barriers, such as, increased arthritic pain presence, more likely they were being single and maybe not having assistance in attending our program. Distance from cardiac rehab was an issue, travel and transportation costs, even if they were relatively close by, or having conflicts with family and work responsibilities. Also the burden of fatigue burden of symptoms such as fatigue and anxiety, as well as timing of referral, were all factors that influenced whether women or not were ready to come to rehab when they were referred. This helped us to tailor our what we consider an intervention, a coaching intervention, when we get the referral to rehab. So unlike programs who might just get a referral, get scheduled from an administrative standpoint, once we get a referral, it's really a coaching intervention that happens with our staff to assess barriers to cardiac rehab, make sure they understand what they're committing to. Is this the right time? And helping where we can, help them through those barriers so that they attend. And Jennifer Price did actually her PhD work looking at coaching interventions designed to increase women's attendance to cardiac rehab. And we know it makes a significant improvement. So even though it's maybe a little bit more work on the staff of cardiac rehab, we know it's necessary and effective to get women through the door and accessing the programs. Other work that we've done that affects our high completion rate really is looking at what women look for or need in terms of safety, the setting, and the environment in the gym. And so we asked our women, what does physical, social, and symbolic safety look like, so that we can make sure all of our offerings would make them feel safe in attending the program. We also looked at how does self-management support look like in the program, so that we can really empower our patients. And then we wanted to take a look also as how do these factors, or how does this sort of reflected in also our immigrant and sort of equity deserving population, and how they access rehab, because we know that some ethnic groups are at higher risk of developing heart disease and having events, but they weren't necessarily the ones accessing rehab either. We've also done some work identifying high degrees of caregiver stress in our population, like I said, frailty before, and severity of depression. And so this helps to inform our practice and how we incorporate flexibility in programming and care in our cardiac rehab program. Finally, a lot of our data generation over the years and knowledge has really helped us to focus on how to optimize access and participation in terms of the delivery of cardiac rehab. So how does a women designed program look different or feel different compared to a traditional mixed gender? The pieces are all the same. We all offer exercise, risk factor optimization, medication support, self-management support, but what is it about a women's centered approach that's different compared to those mixed gender programs? The knowledge that we've generated over the past almost 30 years has really helped our learning health system influence and um, make collaborations and partnerships across our hospital system, but also externally. We are thankful for the collaborations and partnerships internally with endocrinology, with cardiology, the After Cancer Treatment Transition Clinic, and the WISE practice for Indigenous health, in terms of some current projects that are going on. And I just wanted to highlight one of them that's sort of being implemented in the implementation phase as we speak, and that's from pregnancy-related disorders and the risk of future heart disease. So postpartum women with recent gestational diabetes have always been a population that could be referred to our cardiac rehab and would complete what we would consider our high-risk primary prevention group. We generated some data that they could attend, they were successful, it was effective in them, and then we were approached by Lorraine Lipscomb and her group with the ADAPT-M trial to see if the virtual home program, the more health coaching aspect of things, was a feasible and effective program for these postpartum women, and to maybe move that into the community with diabetes educators as part of their sort of follow-up in a postpartum care. And so the data became knowledge that now is informing a current implementation phase in the community, and really transforming health coaching for those women in a culturally tailored manner and a gender tailored manner, to support guidelines in terms of optimizing physical activity, healthy eating, navigating low moods and sleep in that postpartum, especially that postpartum year where women are higher risk, which is really exciting. So again, we highlighted the roadmap of all the, not all, but the majority of the things that have informed our data, knowledge, and practice over the years. And I'd say part of our success was that this was really embedded from our inception. The idea of generating or gathering data in that Microsoft Access portal, so that we had data sovereignty and we could look that the data was was complete and was valid from on a routine basis, and able to pull it annually to provide annual reports to see who we were servicing. We are a program that is in constant evolution with patient trends that really allows for new practices. And when I say patient trends, it's really the population trends. Even though our bread and butter is the cardiovascular conditions, sometimes we get more from certain population groups. And right now we're seeing a lot of low disabling strokes being referred to cardiac rehab. And so our future efforts are going to be looking at that data and seeing what we can learn from that population, because they're fairly new to us, and how we can best tailor our program to meet their needs. Our success is also in our interdisciplinary team. We are a small but mighty team of physiotherapists, kinesiologists. We have a social worker, a dietitian, a pharmacist that we borrow from specialized medicine. And we're all aligned in our vision and passion for women's heart health. So this doesn't feel like extra work outside of our workload. We all want to collect the data because we're really invested in learning from every patient and how we can optimize their experience and their outcomes through our program. What helped early on as well is that our role profiles in our cardiac rehab program really supported our research-based practice as part of our roles. And in our early days, we would include that a lot in our research meetings, have support from our managers, our directors, our cardiology community to do that work. We are also we're lucky that our the staff on our program have been here for a long period of time. I'd say we've been together, this group, for at least over 15 years. And together, we've always had a culture of understanding and change. We're not afraid of change. We've evolved our program many times over the years and have a lot of trust and autonomy within our programs, but also understand our roles and how it's really important that we all work together to gather good data and to learn from it, and how we all are on the same page for changing practice. I'd say going forward, some of the work that we're doing now is we've recently participated in some work setting research priorities and partnerships with patients, caregivers, and clinicians around women's heart health. And so the output of that will help give us some direction of maybe some data that we can look at and knowledge that we can learn. Leveraging technology, I would say, is our biggest opportunity. Since we've shifted to Epic, we've had a harder time harvesting the data compared to when we had it on our Microsoft Access form. And so we haven't been as up to date on some things because the data's not clean. It's really hard to get what we're looking for sometimes. So we're really looking at how do we optimize our use of Epic and data pulling. We have an exciting opportunity to be about creating a command center, which will kind of look like a dashboard, like Rachel mentioned in her presentation, that should give us real-time data to make sure that we're meeting guidelines and we have all of the data that we're looking for to continually learn from those patients. We're also looking to learn from patients about the feasibility of self-referral to our virtual education session. Right now, cardiac rehab is a physician-referred practice, and so how can we involve the patient experience without needing a physician referral to learn more about their heart health? So I'll leave it here because I know we're at the end of time. I want to thank my team. Most of us are in these pictures, minus our clinical dietitian, Helen Emanolidis. But I welcome any brief questions. And if anyone would like to connect with me after, here's my email. And you can follow us on Twitter at WCH Women's Hearts.
That's excellent. Thank you so much, Mireille. What a great presentation. And I really love the highlighting of the opportunities. Just shows that this work is not done and there's so much more to do, but so much amazing stuff has happened. And I like how you really brought that context. We have time for one question. I know we've heard from
Go to
Rulan.
Rachel. Go to Rachel.
Let's go to Rachel. Okay.
Nope, sorry, I'm gonna hand it over to Rulan. I was clapping.
Thanks,
All
Rachel.
right, well, I'll ask the question quickly.
Oh, she's clapping. Okay.
So you've talked about the dashboard, but I think the question is, does the dashboard actually answer the questions that you want? Or is there a pipeline of data that you want to come out and to look at in very specific ways? I think I'm just trying to understand how you're using the data, and then how will you use it to, as you're thinking about expanding it, I guess, and thinking about across the hospital, if people can self-refer, how will that work?
Yeah, so I mean, initially, I'd say, post-COVID, we haven't been as complete in our data gathering compared to pre-COVID. And part of that is how things are collected in Epic, and we having a hard time making sure it's all there when things are, let's say, patient-reported outcome measures are being attached to certain visits, and then we find out they're not really attached. So we've had a lot of issues making sure we have complete data sets. I think the first goal of having this command center is helping us to make sure we have a complete data set across the way so that we can see if there's any, first of all, change in trends in what we're seeing from a patient demographic perspective, especially in terms of maybe how symptomatic they are, where their functional exercise capacity is. And especially around depression and anxiety, to make sure that we're keeping up with standards for cardiac rehab in terms of what we're offering our patient. In terms of going forward, there's certainly lots of things we want to identify. I think the command center is going to help us a lot identify what we want to see. We don't have it in place yet, Roland, so it's all a hypothetical right now of what we'd like to see. We have certainly some ideas, what we want there, and also real-time monitoring for what's happening in the gym. So it'll really help us a lot in making sure that we're collecting good data, but also that we're learning from complete data sets to be able to give the best care to who's accessing the program, which is very different today than it was pre-COVID. So again, we're evolving with or adapting to the patients that come with our program. But I could count on one hand pre-COVID how many low disabling strokes we had attend, and now it's a significant portion of our referral base. So that's a population we need to learn more about based on the data that we're gathering.
Thank you so much.
Yeah, what an excellent way to kick off our new season of the seminar series. I want to do a special thank you to our speakers for your excellent talks. Again, please feel free to reach out to them respectively. And special thanks to everyone who stayed on till the end. And so, yeah, we look forward to seeing you next month with a brand new presentation. Thank you. And we'll see folks in the post-seminar chat shortly. Bye.